Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hi, everybody, and welcome back to another episode. Today we have with us Dr. Sadie Elisseou. It's lovely to have you here. Welcome.
Thank you so much. It's a joy to be here.
So tell us a little bit about you.
I am a primary care physician and I work in the VA healthcare system in the US. Right now, I'm living in Boston. So I take care of US military veterans. I'm also a medical educator and I teach at Harvard Medical School and Boston University. And I'm a subject matter expert in something called trauma-informed care. So I teach clinical health professionals how to take care of patients who have experienced various forms of trauma while also taking care of themselves. And I consult for companies and organizations that wish to address burnout and cultivate well-being. So that's how I spend my time.
There you go. Love it. Okay, so this is right on topic for us. So tell us about you and your journey through medicine and challenges and things that got in the way or part of just how it all went for you.
I knew that I wanted to be a doctor when I was a child. My father is a general practitioner and he is my hero. And so whenever he would be on call answering pages and speaking in a foreign language, CBC and LFTs and metoprolol, I was like, oh man, I need to speak that language. And his white coat always seemed to me like a superhero's cape. And so I applied to medical school at the time that I was applying for colleges and entered an 8-year program to do my training. So in the US, that's kind of a different way of entering medical school. I spent my undergraduate years doing a more humanistic, holistic approach. I did religious studies, I studied abroad, I did other languages, and really tried to understand the breadth and depth of the human experience. And when I went to medical school and did my training in primary care, I felt that I would just start by doing some good in a little community somewhere. But then there was this itch in the back of my mind always to teach, teach, teach. That was always an interest of mine. And as I taught and got exposed to medical students and residents, and as I got my first job at a VA, it became very clear that trauma was something I wanted to learn about and teach about. And the basic physical exam maneuvers that I was taught in medical school seemed to be making my patients visibly uncomfortable. I remember, for example, swinging my stethoscope off my neck to start the cardiac exam, and my patient jumped. And so slowly I started speaking in a different way, using different words. I started moving about the room in a different way and touching patients differently, if in an effort to make them more comfortable around me and comfortable in clinic. And it was a medical student who told me one day that my approach was so-called trauma informed. And when she told me more about that approach, it really blew my mind. And I learned that this framework for supporting people who've been through difficult things can really be an unlock to a whole world of empathy and compassion and care that can transform lives and lead people towards healing. And that has been really transformative in my practice of medicine, in my career path, and even for me to sustain me through this challenging work of primary care.
Oh, that's so interesting that somebody noticed what you had already done
Mhm.
to manage some of the things you were noticing about your patients and then kind of named it for you and took you on a totally different pathway.
Totally different path. And I think you're right that noticing matters. And I've had people ask me, how did you pick your niche or your specialty? How did you decide what you were going to focus in as a researcher or an educator? And I let them know, hey, I did my best to look through medical textbooks and see what am I interested in. I did my best to look through conference agendas and wonder what's the hot topic now. And nothing clicked for me. It was using my clinic as a lab, really, and noticing where the gaps were and how I could be effective. That's what ultimately led to this career path.
Interesting, yeah. So you had been working with veterans. Is there a reason that you had um, gone there as your kind of first job or
Oh,
called?
wonderful question. I made sure that I interviewed for a variety of very different looking jobs. I interviewed for jobs that were private practice, so-called concierge practices. I interviewed for jobs that were university based and were very teaching heavy, jobs that were a mix of outpatient and inpatient. And then this VA job landed in my lap, and it was really a perfect mix of seeing patients and teaching. And I had the opportunity to become the course leader for the doctoring course at Brown Medical School. The VA is less of a RVU driven institution and aligns very much with research and education. So that allowed me to do that. Has great benefits being a federal employee, and the patient population is just immensely beautiful to work with. They're lovely people. They're so giving. They're so grateful. They're really funny, and they're very hearty people. And so being around them has been a gift.
Got it. Yeah. Is there any cultural awareness training for going to work in the VA, especially if you haven't come from a veteran background at all? Was there anything that onboarded you to what your patients might have experienced or some of the things that they might have been dealing with?
Yes, we have rigorous onboarding training to understand military experiences and how that may impact health as well as experiences in healthcare. One thing that I came across in my own reading about trauma is that veterans who serve in the volunteer era in the United States have higher rates of adverse childhood experiences, also known as ACEs, compared to people who have not served in the military. And so this suggests that while folks mostly join the service for very positive reasons like altruism, patriotism, or to fulfill a family legacy, there are others who may be joining the military to escape some forms of adversity. And we know that ACEs do have an impact on adulthood illness, morbidity, and mortality. And so the veterans that I take care of have unique health challenges. They are, in general, an older population and have a lot of physical and mental health challenges, which for me as an internist is really interesting. And it's one of the reasons I go to work.
Yeah, fair enough. Did you see any of that cultural awareness happening in your training prior to going into the
Mm.
VA?
That's been an interesting cultural shift. I'm not sure what it's like in other countries, but here in the US, there's been a very noticeable difference in the way medical education happens over the past 10 years, 20 years. When I was a student, I had the option to perhaps join the cardiology interest group or the dermatology interest group, and that's really where it landed. But nowadays, students are going into school asking themselves, do I want to stop human trafficking or do I want to end climate change? Understanding that we're not here just to treat individual illness. There are so many structural and societal illnesses that have an impact on public health. And so, students of this generation, I find, have very different lenses that they wear upon entering this profession.
Yeah, it's exciting to
Mm,
see. Absolutely. We
totally.
had, I agree. I think when I was doing general practice training in Australia, there were modules available that I happened upon, I think because I was looking after a few veterans dealing with PTSD and wanted to have a bit more idea what was going on. How did they get here? What does it look like to aid recovery? What are some of the frontiers of how to manage this trauma that they've been exposed to. It was very early on. Um, I'm not saying it's early on. It's been around for a long time, but it was more of a self-directed learning. It was something that you
Correct.
really picked up if you were looking for training in that.
Yes, and I think there was in general much more of a leaning into biomedical approaches to health rather than the biopsychosocial model. I think in my med school, we may have had a 30 or 60-minute lecture on nutrition, and that was the end of that story. And so many of my patients come to me asking today about supplements and diet and lifestyle, and it's a whole new world. And so, yes, absolutely. It's not only about pills. There are many more aspects of health in our complex bodies and environments for us to learn about and manage.
Yeah, yeah. All right. So tell us about a trauma-informed approach to our patients. So you've already indicated how you move, how you speak in the
Mm.
room. What are you considering when you're talking to a patient that helps you navigate some of those pieces?
Great question. What comes to mind is that it really is about creating an environment that feels physically and psychologically and emotionally safe for our patients. And for most of us who step onto a medical campus, there's a little bit of discomfort with that experience, particularly for me in primary care, general practice, where I'm doing physical exams. My patients may be undressed or in a gown. They may be perched up on a bench and being touched by a stranger, ask very personal questions about their health, and wonder what horrible things they're going to find out about their prognosis. So it is not a very comfortable, cozy, relaxing experience. Plus, we have claustrophobic MRIs and painful IVs and very scary procedures where people undergo anesthesia and perhaps may be in pain with wound healing for days or months. So we need to acknowledge that stress at a minimum is pervasive throughout people's healthcare experiences. So an environment of safety involves many things. Part of what I try to do when I enter a room is I first, before I even knock on the door, and knocking is important to alert the person that you're going to be entering, I just check in with myself, make sure that I take a deep breath and that I'm in a grounded, present space to be able to enter the room and help that person feel welcome there. So I greet the patient warmly. I say, "Welcome. It's so wonderful to see you. Thank you for making the time. I look forward to hearing how you've been." And that involves me sitting down, being at eye level with the patient, making appropriate eye contact, ensuring that my body posture is open, that my hands are out of my pockets. So it's always clear to the veteran's brain what I'm about to do with those hands. I'm going to speak at an appropriate volume. I won't make any quick movements or very loud noises. And I'm going to listen and be clear and transparent. What matters is our nonverbal communication as well as our verbal communication and our behaviors. I want to try to have the exit door free and not blocked by anyone or anything so that our brains can perceive that we have an exit at all times. And when I stand near the patient, I try to stand at their side in their peripheral vision. I'll give you just one clear example of that. When I was in medical school, I was taught to examine the thyroid gland by standing directly behind the patient and wrapping my hands around their neck, right? With my thumbs in the back. And that can simulate strangulation. So it may be a more sensitive, person-centered, trauma-informed approach to stand at the patient's side within their peripheral vision, my fingers fully extended on the front of the neck, and letting the patient know what I'm about to do and why. And I'm not going to ask them to do things for me. I hear the phrase for me a lot in healthcare. It can maximize that differential of power between the patient and clinician and can even be sexually suggestive, like hop on the bed for me, or take off your shirt for me, or bend over for me, or even swallow for me for the thyroid exam. So we can just be more mindful and deliberate about our practices.
Okay. So that permission ahead of time, here's what I would propose that I would like to do, so that they know what they're expecting, the positioning of you, how you're using your hands, even how you're taking your stethoscope off your neck, just
Totally.
being mindful of. And I think most of us have sat on a physician's examination table and
Right.
had a less than ideal experience.
Correct.
So we can, and in the busyness of medicine, like we're given such short consultation times in many of the areas in medicine, and you can absolutely appreciate from the physician perspective why they're trying to rush through this.
Totally.
So we get it, and but at least we can be mindful of how we could proceed better and
How
more
we proceed
mindfully
better.
for our
That's right.
patients at the same time.
That's right, exactly. It doesn't have to take that much longer. There's a difference between, for example, if you're going to be checking for jugular venous distension, grabbing the patient's head on your own and moving it for them, or asking, could you turn towards the wall? It can be very short, very simple. Or in an emergency room setting, rather than just introducing the digit into their rectum, you can say, we do need to check a rectal exam to make sure you're not bleeding.
Mhm.
It doesn't have to take long, but these can be helpful opportunities to remind oneself that we are humans with other humans when we are in a patient encounter. And touching in and plugging into that very human experience helps me mitigate burnout, and it refuels me as well. Knowing that I can be heart to heart and eye to eye, mind to mind with a patient, laugh when they say something funny, feel warmth inside when they say something heartwarming,
Mhm.
feel concern for them when they're expressing their sorrow, and rejoice with them when they're sharing their joy. That's part of why we went into medicine to begin with. And it can get worn out of us, and
Mhm.
things can get really clouded with the burden of what we're tasked with, and for so many other reasons. But it is possible to tap back in.
Yeah, I love that. Is there anything that you've done with your staff, or are they already kind of good at this, that helps before you're even in the room?
That's a wonderful question. I don't think that trauma-informed clinical skills training is ubiquitous or standardized yet. I happen to work with a really exceptional team. And in general, people enter the healthcare profession with the desire to be helpful. We often call ourselves healers or empaths, or we just want to do good in the world. And so there is a pervasive sense of kindness around. However, many times trauma-informed clinical skills are learned skills. They're not always inherent. I would say that our nurses do a wonderful job of entering the room in um, non-confrontational way, and they welcome the patient by their name. They introduce themselves, and then they have a seat so that they are eye to eye with the patient. Transparency is really important when it comes to being sensitive for people who are trauma exposed, particularly those who have, let's say, post-traumatic stress disorder. Oftentimes, in a trauma scenario, there is a rupture of trust and an abuse of power. And so there is a lot of mistrust when people come into the healthcare setting, particularly because there are those power dynamics that are already ingrained. So when a nurse says, "Hi, Mr. Stewart, it's really nice to see you again. I'm Sandy. Remember, we got to chat at your appointment in June. I'm one of the nurses here working with Dr. Elisseou in primary care." That already frames the discussion. It helps to orient the patient's mind as to where you are, why you're here. This is a medical appointment. This is for your health and your well-being. This is Sandy. She's so friendly. She's someone I met before. And
Mhm.
again, that eye to eye conversation, and then asking permission. Today I'm here for about 5 minutes before you see your doctor. My goal is to do vital signs, check your blood pressure, and answer a few questions like checking on your medicines. Is that okay? And so the agenda is set, it's transparent. You're here for them. Let's partner together. We're a team. And can we proceed?
Yeah. Okay. So you can see in some scenarios, such as you're off to the obs and gynae, and in this clinic specifically, you are popped in a room and told to undress and put a gown on and wait for the doctor. So you can see how the approach of the person doing that is going to set up already ahead of time the patient's level of stress, um, and so that coaching and teaching of our staff beyond ourselves is going to make a huge difference to then how, even if you have the best trauma-informed care, but your staff is unfriendly, unkind, unaware, just unaware of the way they're proceeding, how they're greeted at the front desk. We get from time to time you hear, our patients are cranky from the minute they walk in the door because they were greeted in an unfriendly way. That there was crankiness on the phone. You hear about how that has jaded the patient's experience, and it's created for you longer in the appointment to calm down that patient and get to the needs of that patient's care today. So it matters. All of us matter.
All of us matter. Totally
All of us
true.
matter.
And before I had my eyes opened to trauma-informed care, I used to view patients' behaviors when they were agitated, angry, or irritable as really annoying. And I would blame and shame the patient. That mean guy is here to wreck my day, you know? But in a trauma-informed paradigm, we're moving from the traditional and accusatory question, what is wrong with you? What is wrong with that patient? To the more compassionate inquiry, what happened to you? What has happened to that patient that informs that behavior? And when we look at things with that shift of mindset, it opens the door to curiosity and empathy. And so now when I see those behaviors, I wonder, is this coming from a place of pain? Is this coming from a place of fear? And what can I do to help ground the patient? And there are many strategies that we can do when we enter a room. There's something called co-regulation, where we can actually calm down with one another. And if I model calm in my nonverbal and verbal communication, that can help the patient to get into a calm body as well. And also, I can validate and acknowledge what the person's experiencing. If I walk in and they say, I've been waiting here for 30 minutes, I can say, wow, that's a long time. That sounds really frustrating. I'm sorry. And that helps the patient feel heard. Once they feel heard, we can get back to business together.
I love that. Know that when I returned to Australia 2 years ago, one of the requirements is cultural awareness training, and then the ability to do some even further additional training in mental health for
Hmm.
our Indigenous patients, which was
Hmm.
really valuable because it brought into play a lot of this reminding of our trauma-informed care for other populations that are interacting with the healthcare system with other things happening that culturally that play into how this patient interacts with me in the room, and how I can be more culturally sensitive to help the patients, help me understand what the patient's understanding, and help the patient understand what we might be able to do in terms of their health if they choose to. And just having that ability to, one, acknowledge that I needed that help to understand how to help my patients, but two, are we spreading that further than us? Are we helping the environment? And they talk about how we can set up our practice, what we put on our walls, what's in the waiting room. How do we make this something that's welcoming for our patients so that they know that they're welcome here?
Totally. Healthcare environments are not always healing environments through and through. There's a lot that is really activating and uncomfortable. So we have a role to play in making it better for people and for ourselves.
And for ourselves. So, can you talk us through what it looks like to have a workplace that is supportive of um, the physicians, clinicians, the staff? Because we're hearing really difficult stories from patients where at times we are assaulted, abused, having our own traumas within environments that we're working, whether that's coming from patients or staff or a multitude of places. What does it look like to start doing this work for ourselves, to look after us too?
That's the question, right? There is no one size fits all. There's no cure. There's no immediate solution. This is a very chronic problem that is multifaceted in cause, and so it requires long-term, creative, and multi-pronged interdisciplinary solutions, right? So, what I have found helpful for me in the workplace is making sure that I'm caring for myself. And self-care is not always a luxurious massage at a spa and a bubble bath every night, right? Like, who has time and money for that? So, self-care can be as simple as taking an actual mindful deep breath in between patients because we have been trained to go see a patient, horrible things just happened to them. Maybe there was a loss of life, maybe a new terrible diagnosis, maybe it was a child, maybe who knows what. And, 15 minutes later, move on. You have more to see. So taking a breath, taking a break, going to the bathroom, going for a 5-minute walk, calling or texting a friend, debriefing with your colleagues. It can be the physical therapist, it can be the social worker, it can be anybody. And I'm very fortunate to work in a very kind, warm environment with great people around me. I once spoke with a psychologist who gave me some advice about how to resist burnout. And she told me, make sure you have a rockin' home life. And I thought that was great advice. And I try my very best, even physically, to put my hand on my head and turn off work before I open the door to my house, because I want to give my family the best of me, not the rest of me, right? That's something that a friend told me once, and I thought it was great. I want to give them the best of me, not the rest of me. I've also tried intentionally to, in partnership with my hospital's leadership, to craft a schedule that is varied and intentionally structured to insert my interests into that schedule. So all I need is a precepting session where I'm teaching on trauma-informed care for an hour and I'm a new person. And so I have time built in for scholarship. I have time built in for committees. I have time built in now for consulting and speaking. Right now I'm part-time from clinic. I'm at the VA 4 days a week, and I have 1 day a week to do my own business on trauma-informed care. So that also helps to sustain me. And I have to get pretty serious about my time management skills. We all have had to become experts in a way in our own time management out of necessity. It's something that I really nerded out and geeked out about for a while, and I've been asked to teach time and workload management now for national and international healthcare audiences. This is something I have found hugely crucial for my survival. And so for me, I have to cut off my day at a certain time to go pick up my kids. That's not negotiable. I have to cut off work at a certain time to get a certain number of hours of sleep. That's not negotiable. And there are other strategies that I've worked in with my team to make sure that we can all sustain our days.
Yeah, I love that. Um, is there a way, do you advocate that people have someone outside of medicine that they are talking to, like the psychologist that you mentioned, um, about our days so that further encourages healing?
I think that's a very important question for medicine to grapple with. It's not been an issue for mental health and behavioral health because, at least in the United States, there is a built-in system of supervision for mental health professionals. I remember when I was doing my mental health rotation, with a psychiatrist. He said, okay, 3 o'clock, gotta go. I'm gonna go see my therapist and I'll be back. And I was like, well, that's really interesting. He said, yep, we all here have a 1 hour session every week with our own therapist. It's the structure. And there are many iterations of that in different ways. So that's something that's pretty foreign to us. We in medicine have been trained to be very stoic. We are doers and we are thinkers. We are not feelers. But the problem is, it's impossible to walk through water without getting wet.
Mm.
The very challenging work circumstances and clinical scenarios that we face cannot be expected to not have some kind of an impact. And most of the time, it's a beautiful, transformative impact. But sometimes those get a little tricky and they can be a blockage for us in moving forward. So I think it is important to think about employee assistance programs that are more accessible and more promoted within clinical spaces. I think it's important to advocate for clinicians having their own mental health professionals accessible, whether that's a monthly meeting or a weekly thing or just once a quarter to have a check-in. I think it's high time now for us to acknowledge that mental health is not some side woo-woo thing, right? Mental health is brain health. Our brain is an organ that we're very familiar with. We have a whole field of neurology and neuroscience, but mental health is absolutely part of that.
Yeah. Interviewed psychologists here and they've said the same thing. It was a requirement of their training that they had a psychologist. If you're going to go become a psychologist, you need to have had one and
Love
experience
that.
having one and the expectation that they continue having their own psychologist as they're being a psychologist. I'm like, of course,
Right.
that does make sense. And it
Yeah.
makes sense that what we hear and see, like you said, walking through water, we're going to get wet. And hearing people's lives, we're going to hear the good, the bad, and the ugly.
That's right. That's right. I remember speaking with a social worker because I had had a challenge that day with a very difficult story that my patient had told me about his past traumatic experiences. And the social worker told me, Sadie, do not replay negative thoughts. Let them die a natural death. And I thought that was brilliant. And I've remembered it all these years since. So, of course, it can be helpful to get help.
Yeah, absolutely. All right, and tell us about a little bit of this way you structured your day to help you prevent burnout and improve wellness, some of that time management piece, because I think that a lot of my listeners are already working on how I'm looking after me too within the clinical day. So tell us some of the things that you did to help you get out of there kind of feeling like you're on top of your game.
Sure. I think one of the things that I did early on was schedule breaks, like sprinkle them throughout the month. I remember taking a day off a month for a while instead of having my annual leave or vacation or whatever you call it just in blocks. I would have something to look forward to. January 27th is off and it's just for me. Or I would schedule 2 hours off in the morning so that I got to enjoy my cappuccino at home with my new espresso machine, or have breakfast with a friend and go for a walk before starting the workday. Those breaks, time for me can really feel like you are claiming your life again, and you can do whatever your priorities are in that time. Another thing that has been very helpful for me is understanding the model of batching. So, batching our tasks. I find, for example, that Mondays are very packed with clinic appointments. And so I'm not going to expect myself to sign any forms, do any phone calls, or address any other labor on Mondays. That's for patient appointments. Let the rest go. On Tuesdays, that's the day when I have the afternoon blocked for scholarly work. So that's teaching, that's meetings with other colleagues, that's writing manuscripts, and that's what I expect myself to do that day. Wednesdays are my day off to work on my speaking and consulting business. Thursdays, I have more time to address more clinical alerts like medication refills, conversations with specialists, etc. And then Fridays is a bit lighter. I have more admin time sprinkled through the afternoon so that I can make phone calls to patients. So rather than, let's say, looking at my cabinet that's packed full of paperwork and every time I look at it, it's yelling at me. It's saying, you got to do it now. You got to do it now. I look at it and say, Thursday, you know? So that has been helpful. And then also using my team not only to delegate tasks to them, but also to work as a well-oiled machine. So we have this online system where I work, it's Microsoft Teams, and the nurses will type into a chat things that are urgent for me to look at that day. I may have hundreds of alerts in my box, but they're going to tell me that this gentleman needs this medication picked up today at the window. And so that's what I'm going to do by the end of the day. I also ensure that I finish my patient's notes in between appointments. So if I see Mr. Jones at 8 a.m., by 8:30, Mr. Jones's note is complete. I can do other tasks at the end of the day, but I will save brain energy and save seconds and minutes of my time if my thoughts about Mr. Jones are wrapped up by the time I see Mr. Smith. So that I think has been a big energy and life saver for me. And setting limits. 5 o'clock, 5:30, that's it. I'm walking out. So those are some things that come to mind.
Yeah, I love that. That's just a good way to glimpse into your day and see how have you sprinkled in you in addition to your patients, how have you thought about wellness and burnout prevention? Because we all do things differently and we all have different capacity for setting up our schedules in different ways. And some of us are really locked into what the employer will have them do. But even so, starting to be curious about how can I look after me within this environment?
Yeah, we only have a certain amount of capacity for deep work and thinking.
Hmm.
It's not productive for me to sit in a chair and be thinking intensely and working intensely for 2 hours. Our brain craves breaks and requires them to keep going. And so I used to be of the mind that no, I can't take a break over lunch. I'm just going to do my alerts and plow through. And yeah, it's important, but now every time I'm at the hospital, it's required. I have lunch and then I go for a 15-minute walk. And that's crucial for my health. That's an investment. It helps my brain to clear. It helps me come up with creative solutions. It helps me to feel like I can move on with the rest of my day and improves my longevity and cardiovascular health. So breaks are required.
And helps your insulin resistance too.
There we
Okay.
go. Exactly.
Learning about recently. All right. Let's talk about models that you might have seen done well. So when you've gone and spoken about wellness and burnout and trauma-informed care, have you got any examples of workplaces or physicians who have really put this into effect in a really positive and meaningful way?
Yes, and this is something that has become a more popular subject in recent years. There are entire public school systems that are becoming trauma informed, entire legal practices, and of course, health systems. So I've had the privilege of working with certain health systems here in the US who are integrating a multi-phased structured implementation program for trauma-informed organizational development and culture transformation. And I think with trauma-informed care, what's nice to know is that there's a little bit of theory involved. You know, what is stress? What is trauma? What is the neurobiology of trauma? And then what are ACEs and how do they impact health and disease? But a lot of it can be very practical applications. As I mentioned before, how to stand and position oneself and speak when examining the thyroid, how to communicate to patients in a way that's sensitive, how to take care of ourselves and manage secondary trauma exposure. That's a big deal. So there are very practical solutions, and it becomes a new way of thinking and a new way of being. I haven't had anybody come up to me after a talk and say, you know what, Dr. Elisseou, that just doesn't make any sense. I disagree with the whole thing. Usually people are like, you know what? Yeah, I notice the effect of stress on my patients. I notice the way it shows up in a visit, and I'm going to experiment with these new strategies, and I think it's going to be helpful. And once you see it, you can't unsee it. It's like, drinking the Kool-Aid or putting on new colored glasses to see the world. And it's not always about seeing trauma everywhere. It's about seeing the beauty of healing and human connection everywhere. And so I don't, it's not always required to have longitudinal exposure with multiple trainings over and over and over again to this. I think it catches on. And I think once you see it, it can become integrated in whatever role you have, whether you are a phlebotomist doing trauma-informed blood draws, or you are the CEO of a major health system and you're thinking about trauma-informed leadership. And it can become attached to and aligned with whatever the mission of the organization is. If you're thinking about safety in organizations and HROs, it can be aligned with that. If you're doing diversity, equity, inclusion, and belonging work, it can be attached to that. So I remember a time when patient-centered care was a new phrase, like a totally new idea. And it wasn't really, but this is kind of just language that adds to the wonderful things we're already doing.
Got it. Yeah, I love that. All right. Is there anything we haven't spoken about that we should be talking about before we end our conversation?
I think I just want to encourage your listeners that they're doing excellent and important work for their patients. If they are clinicians, they're doing good work. It's also important to look at oneself as a patient and sustain yourself for this good work moving forward so that you continue doing it. You matter. Basically, we all matter in a system. The patients matter, their families matter, our staff matters, our administrators and leaders matter, the building matters, the system at large matters, and it all deserves attention and care. And so I hope that you do have a rockin' home life. I hope that you sleep well and you go for a walk and get in your exercise. I hope that you build in a varied work schedule that includes all of your diverse interests. I hope that you can continue practicing, honing your time management. And I hope that you feel loved and thriving.
Love that. How do people get hold of you if they're looking to learn more or learn from you?
I think that most people can just search for my name on the internet. I do have a website, www.sadie-elisseou.com, and I would be happy to continue the conversation offline. You're welcome to contact me through that website.
Thank you so much for this conversation.
Thank you so much for the invitation. Take good care.
All right. Bye, everyone. Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have Charting Champions for physicians and Smarter Charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.